Good evening, everyone. I would like to welcome you all to the second Journal Club meet by SRC. We are excited to have you join us as we dive into the topic the influence of Caesarean section scar on the mean pulsatility index of the uterine artery Doppler between 20 and 34 weeks of gestation. Our presenter for the evening is CS Pranav Bhat from second year, and we are honored to have Dr. Ashakiran ma'am, Dr. Gayatri ma'am, and Dr. Sushma ma'am as our moderators. Thank you all for being here, and let's make this a great session. Pranav, are we good to go?
Yeah, am I audible?
Yes, you are. On to you now.
Thank you, Fazlu. So, hello everyone. I'm Pranav, and I'll be presenting the second Journal Club meet of this year. So, as Fazlu said, the title is Influence of C-section scar on the mean pulsatility index of the uterine artery Doppler between 20 and 34 weeks of gestation. Talking about the journal first, the article was published in the journal called Dept, which is the official organ of the German Society of Gynaecology and Obstetrics, with a journal impact factor of 2.4 and citation indicator of 0.78. This indicates that the journal performed worse than average, which is represented by a citation indicator of 1. Talking about the authors of the article, we have 7 authors. All of them are from related departments of gynecology and obstetrics and Department of Radiology. So we have no guest or ghost authors. So, talking about the abstract of the article, the abstract is divided into objectives, methods, results, and conclusion. So, talking about the objective, the aim of this study was to assess the influence of C-section scar on the mean pulsatility index of the uterine artery Doppler between 20 and 34 weeks of gestation. A secondary objective was to assess the association between previous C-section and adverse maternal and perinatal outcomes. The methods would be a retrospective cohort study, and the variables and results will be discussed later. The abstract has sufficient information, which is informative and a balanced summary. The introduction, talking about the background and rationale. The evidence in the literature suggests that women who undergo C-section in a subsequent pregnancy are more likely to experience adverse pregnancy or perinatal outcomes. Uterine artery Doppler is one of the methods to assess the progress of pregnancy to identify possible alterations in fetal development. The other methods would be biophysical profile, triple markers, and so on. So, using the Doppler of the uterine arteries, we can assess the vascular resistance using the variables like pulsatility index, resistance index, and systolic diastolic ratio. Of these, pulsatility index, that is PI, is the most commonly used index. Discussing about the methods, the study design.
No, should we wait or till you complete the presentation, or can we interrupt in between?
Ma'am, it would be better if we could discuss everything afterwards.
After the present, yes, yeah, yeah.
Okay. So the study was a retrospective cohort study, which is confusingly told to be prospectively collected. There is no such thing called prospectively collected. A retrospective cohort study is always following from exposure to outcome. So the setting would be the fetal medicine unit in the Ops Gynae sector. And talking about the participants, pregnant women who had the deliveries between March 2014 to 2023 were grouped according to the presence of previous cesarean section. So these databases of the pregnant women were collected through an active search of the Astraea database and electronic medical records using the SOLMB system. The two groups were those without previous C-section and at least one previous C-section. The inclusion criteria were women who were less than 40 years old with singleton pregnancies, whose gestational age was confirmed by first trimester ultrasound and who had undergone ultrasound between 20 and 24 weeks and 28 to 34 weeks of gestation. And women who are not using heparin or aspirin is erroneously given as inclusion criteria here. And other criteria like women with no history of uterine surgery other than C-section, absence of fetal malformations and all and or chromosomal defects diagnosed during pregnancy or the postpartum period. These are rightly to be included in the exclusion criteria and are erroneously included in the inclusion criteria. And exclusion criteria is not mentioned specifically. Talking about the assessment of variables, the following variables were evaluated: gestational age at the time of ultrasound examination, estimated fetal weight, mean pulsatility index of uterine artery Doppler, and mean multiples of median pulsatility index of uterine artery Doppler. This is done through ultrasound. So, talking about the methodology of examination, the pulsatility index of the uterine artery Doppler were assessed transvaginally according to the steps, and pulsatility index of the right and left uterine arteries Doppler was calculated when at least 3 consecutive similar velocity waves were obtained, and arithmetic means of the pulsatility index of the right and left arteries was calculated when assessment was performed by the abdominal and transvaginal routes. This is actually contradicting to the first part where pulsatility index was assessed transvaginally. So there is a confusion between abdominal or transvaginal ultrasound. And whenever I mention mean pulsatility index, it means the arithmetic mean of the right and left uterine artery pulsatility index. So this is how uterine artery Doppler looks. The uterine artery Dopplers have peak velocities 50 centimeters per second, which this velocity is used to differentiate this vessel from the arcuate arteries. So talking about the methods, to calculate the multiples of median pulsatility index of the uterine artery Doppler, the mean pulsatility index of the uterine arteries of pregnant women was divided by the median of the mean pulsatility index of the uterine arteries. This was adjusted for gestational age, body mass index, parity, diabetes mellitus, and pregnancy-induced hypertension. So any evidence of bias was adjusted for. Talking about the sample size calculation for the primary objective, using a standard effect size of 0.25, a power of 80% with 95% confidence interval, and a significance level of 0.05, a sample size of at least 299 participants in no prior C-section scar and 149 participants in the prior C-section scar group would be required to assess the effect of prior C-section scar on the mean pulsatility index. So this study confusingly mentions various different sample sizes for different objectives. So this is usually not the case where we take single sample size and analyze primary and secondary objectives. Talking about the statistical analysis, the normality of the distribution was assessed by D'Agostino and Pearson normality tests. If they were not normal, that is non-parametrical, they were presented as medians with minimum and maximum values. Mann-Whitney and Kruskal-Wallis tests were used to compare variables between groups. The Wilcoxon test was used to analyze paired continuous variables. Categorical variables was described using absolute and percentage frequencies, and chi-square test was used. Spearman's correlation test was used to determine the association between number of C-section and mean pulsatility index. To calculate the odds ratio of adverse outcomes during pregnancy, that is for the secondary objective, binary logistic regression was used. So to compare the population with the history of previous C-section and without history of previous C-section, adjusted prevalence ratios was calculated using modified Poisson regression models. The results of the article are displayed under the following subheadings: maternal characteristics of the studied population, So this is a flow diagram of the cases included in the study. Talking about the maternal characteristics. So of the pregnant women with previous C-section scar, they had higher number of deliveries and a higher BMI, a higher alcohol consumption and diabetes mellitus during pregnancy, and pregnancy-induced hypertension. Talking about the maternal characteristics of the study population, there are two tables which show the ethnicity, mode of conception, placental location, type of delivery. Influence of the presence of previous C-section scar on uterine artery Doppler indices. This shows that pregnant women with previous C-section scar had a higher median of mean pulsatility index of uterine artery and higher median of multiples of mean multiples of median of mean pulsatility index of the uterine artery than pregnant women without previous C-section. So influence of the C-section scar and placental location on the uterine artery Doppler indices. In pregnant women with previous C-section, there was a significant reduction in mean pulsatility index and multiples of mean pulsatility index of uterine arteries Doppler between 20 to 34 weeks of gestation. The median difference was minus 0.28 and minus 0.03 for a mean pulsatility index and multiples of median of mean pulsatility index with a statistical significance. Talking about the final secondary objective, the influence of previous C-section at 20 to 24 and 28 to 34 weeks of gestation on uterine arteries. The secondary objective doesn't talk about the pulsatility index in itself. So this could have been a different study altogether, talking about the uterine artery Doppler indices and the influence of previous C-section scars. Talking about the discussion, in the recent era, there has been a tremendous increase in C-section rates. The causes would be due to elective C-section, advanced maternal age at first pregnancy, decrease of vaginal delivery after one C-section, rare breech deliveries vaginally, and increased estimated fetal weight, and maternal chronic diseases. Talking about the conclusion, pregnant women with previous C-section had higher uterine artery resistance, and the number of previous C-sections had a significant influence on the uterine artery Doppler between 20 to 24 and 28 to 34 weeks of gestation. Previous C-section was an independent predictor of postpartum hemorrhage and Apgar score at the 5th minute less than 7. Pregnancy-associated arterial hypertension and number of previous deliveries influence the risk of composite neonatal outcome, but not the presence of previous C-section alone. So, talking about the conclusion, will this article change our clinical practice? Right now, uterine artery Doppler has shown to be a predictor of adverse maternal perinatal outcomes, and inculcating this in our clinical practice would be of clinical use. So the article supplementary material is given, and there have been no conflicts of interest. Thank you.
Okay, nice presentation, Pranav.
Yes, ma'am.
Sushma ma'am, your comments?
Asha, ನೀವು ಹೇಳಿ because my comments are very based on only methodology. I think subject wise you only have to say.
Yeah, subject wise, maybe we'll start from the beginning. So,
Yeah.
okay.
Yeah.
So, Pranav, could you tell us what were the points which were nicely done in this article?
Like the uterine artery Doppler was,
No,
associated
not
with
not only related to obstetrics, the whole article as such, the paper as such. Have they described the methodology nicely? How
yes,
about the
ma'am. It is
methodology?
very detailed and described.
Yeah, detailed and very nicely described. And what about the statistical tests and methods, which maybe Sushma ma'am will tell it again? Very detailed and nicely described. And anything else? What about the
Ma'am,
numbers studied?
the sample size calculation was a bit erroneous.
Huh.
We usually calculate one sample size per study, but
Hmm.
here they are specifying a lot of different sample size for different outcomes.
Okay, let us go from the first. So maybe we'll go from need for the study. So how will you justify the need for the study here?
Ma'am, in the
So there
introduction
is
itself,
there is a previous cesarean section pregnancy. So we know that there are adverse maternal and fetal outcomes. And what are those adverse maternal and fetal outcomes? Have they described it in the introduction?
yes, ma'am, like it is
Huh.
associated with complications like
Hmm.
IUGR,
Hmm.
preeclampsia, and
Hmm.
reduced APGAR scores.
Okay. So whenever we talk about previous cesarean section, maybe FGR, preeclampsia, we don't tell that as the first thing. So if you go and do the literature review, the previous cesarean pregnancies are usually associated with a repeat cesarean and the operative morbidity associated with that, and also increased incidence of adherent placenta and placenta previa. So we
Yes,
less
ma'am.
likely, yeah, we don't discuss FGR and preeclampsia. There is no association between previous cesarean delivery and preeclampsia as such, and also previous cesarean delivery and FGR. Okay. So anything else? Anything else apart from this? How will you justify the need for the study? One is literature review, should be done nicely. Maybe what is the prevalence of these complications like placenta, adherent placenta, FGR, preeclampsia. Preeclampsia and FGR may not be associated, or even if they are associated, there wouldn't be a strong association. So that you cannot be quoting as the introduction part. Maybe you can quote the adherent placenta because we are very sure that it is high risk for adherent placenta, previous cesarean section. Anything else?
That was all I could
Yeah.
think of.
What are the outcome measures they are looking at?
They are saying they're looking at the influence of the previous C-section scar and number of
Huh.
previous C-section scars on the pulsatility index.
Pulsatility index. Okay. Yes. So coming back to the pulsatility index. So whenever we do a research, there should be a strong need for the study, isn't it? So, and pulsatility index in a normal low risk woman or even in a high risk woman. So do we do it routinely? We
No,
don't
ma'am.
do it routinely. Yeah,
Yeah.
we don't do it routinely. And we don't do it even in high risk cases also, but some high risk cases like past history of preeclampsia, we may do the pulsatility index. So basically here what we are detecting by pulsatility index is whether this uteroplacental circulation here is normal, going to be normal, or whether it is going to be compromised because of the high resistance in the uterine vessels, and it is a risk factor for preeclampsia, risk factor for FGR. Maybe indirectly they want to say that it is a high risk for preeclampsia and FGR if they prove that pulsatility index is high in previous cesarean. You got the point?
Yes, ma'am.
Huh. So it is that way. So there are very few indications where we do the pulsatility index. So past history of preeclampsia and other risk factors for preeclampsia if it is there, or risk factors for FGR. Otherwise, we won't usually do the pulsatility index. What is the reason we don't do is the method of exactly how to measure the pulsatility index is not standardized. The method should be standardized because one radiologist does by one method, another radiologist does by another method, so there can be inter-observer variation. So there is no, it is not standardized. And one more thing is at what weeks exactly we have to measure, where we can, the predictivity or the prediction value increases. So that we don't know whether it should be done at 12 weeks, 16 weeks, when exactly if we do the predictivity value increases, we don't know. So that is why it is not a routine practice. Routinely at 11 to 14 week scan, we include it along the 11 to 14 week scan and do the Doppler. But here in the methodology, what they have done is, I don't know why they have done the pulsatility index for so many women, low risk and previous cesarean also, isn't it? That is what they say, that these women have undergone uterine artery PI measurements already.
Yes, ma'am.
So yeah, that they should be defining. Is it a standard practice in their institute to do it routinely for everyone? Because it is not a standard practice according to the antenatal care guidelines. So that they have to define, or basically, or they have done it totally for a research purpose. And here one more controversy is, if they have done it totally for a research purpose also, so it has to be a prospective study.
Correct,
Okay,
ma'am.
so yeah, so here it is a cohort study. Can you comment on the study design here?
Yes, ma'am. So
Yeah.
it was a retrospective cohort study where
Hmm.
they went through the medical records of the previous pregnant people,
Hmm.
and from exposure, that is
Hmm.
previous C sections, they went on
Hmm.
to the outcome, that is pulsatility index.
Yes. So they took pulsatility index as a risk factor if it is high, and then they are going to see what is the outcome. Now they have taken cases who have come for delivery. So why usually cohort studies are not done? Because they have to take the risk factor and follow for a long time for the outcome to happen. So that takes a very long time, but I don't think 9 months is a very long time. They could have as well done a prospective study, isn't it? So they could have done the measurement of pulsatility index and then followed up these patients and looked for what outcome they are expecting in this same in the article. Similarly, they would have mentioned those outcomes in the prospective study also. That could be one improvisation on this study rather than taking the retrospective data. What happens if they take the retrospective data? What are the demerits of this kind of a study?
Like the patient, maybe the patient would not be available for any, if we need any other extra data. That's
Yes,
why they become
very
exclusive.
good. So documentation. So whatever data we need, we don't know whether it is documented in those records or not. So we may have to exclude some of these patients if we don't get that data. And we don't know how many of them actually had undergone pulsatility index Doppler studies. What if some women have not undergone the Doppler studies? So they will be again excluded from the study. So it's always better to do a prospective study, and 9 months is not a long duration, maybe less than 9 months only, because we'll do it at around 11 to 14 weeks gestation. Yeah, and you had a doubt about they have mentioned twice whether it is transvaginal ultrasound or transabdominal, isn't it? You had a
Yes,
doubt.
ma'am.
What was the doubt?
In the during the initial part, they've told uterine artery Doppler was done transvaginally, and
Yes.
after the methodology, they've told both transabdominal and transvaginal ultrasound was considered.
Okay. So maybe in the earlier period of gestation, they have done only transvaginal, and in the later period of, they have done it up to 34 weeks. So up to 34 weeks or 32 or 34.
34.
Yeah, up to 34, then they have included transabdominal examination also. Yeah, and again, this is again a controversy why they have done Doppler up to 34. That is not at all a standard practice because their prediction means you have to do it well before the disease occurs, isn't it? Doing uterine artery Doppler at 34 is not advisable. It doesn't act as a predictive investigation. And yes. So, how could you improve on this study? Tell me all the points how you could improve on this study. If you had to replicate the same study, how you would have done it?
As you said, instead of a retrospective, we could make it prospective.
Yes.
Then we could, create uniformity in the period of gestation at which the Doppler was done,
Yes, very
and
good. Yes.
doing the Doppler early to act as a useful predictor of further complications would
Hmm.
have been helpful. I would do in
And
a.
yes, anything else? Sample size?
Yeah, sample size. I take a single sample size based on previous parent articles and then go about it.
Okay, fine. You will take a previous parent article and you will calculate accordingly. Okay, so what about the study population? You would take low risk or high risk?
Um, because we have
Apart from
in
the
the
previous cesarean section.
previous history of preeclampsia, previous history of
Yeah.
early
See,
medium.
if you want to prove that previous history of cesarean section has adverse perinatal and maternal outcomes, then you have to exclude previous risk factors which anyway will lead to adverse maternal and perinatal outcomes.
Yes, ma'am.
Okay, like previous history of preeclampsia. So if you exclude that, then this pregnancy, uh, if you include previous history of preeclampsia, what will happen is she may develop preeclampsia in this pregnancy. She may have raised pulsatility index in the uterine artery, and then she may have adverse maternal and perinatal outcome. So cesarean scar and preeclampsia, you cannot correlate. It can be just because of preeclampsia, the adverse maternal and perinatal outcome. So maybe initially you can do this study in a low risk population. Low risk in the sense previous cesarean is a high risk, of course, but low risk in the sense you have to include other risk factors, exclude other risk factors which already have a effect on the maternal and perinatal outcome. Maybe past history of GDM, past history of preeclampsia, and yes, past history of abruption, past history of FGR. These all you may have to exclude. Have they
Understood.
excluded this?
No, no, no. They were included to analyze the secondary objective.
Yeah, and maybe the in the conclusion, can you read out the second part of the conclusion?
Should I go to the slide now?
No, no, you can just read it out. You have your slides, right? Okay, you can go to the slide. Second part of the conclusion. Yes, pregnancy-associated arterial hypertension and number of previous deliveries influence the, yeah, you can see. What did you understand by this?
The higher risk, that is uh, the previous deliveries
Huh.
and arterial hypertension influence the risk of the neonatal complications.
Composite neonatal outcome, but not the presence of previous cesarean section alone. So how can you solve this problem in your next study, which you are going to replicate? You understood my question?
Yes, ma'am. Since the
Huh.
study concludes that just including previous C-section alone will not influence the risk of neonatal complications.
Yes.
So
So,
I
yeah, the composite neonatal outcomes were not related with the presence of previous cesarean section alone. So they were influenced by other factors like the number of previous deliveries. This can be included. Irrespective of the previous deliveries, you can include it in your study population. But pregnancy associated arterial hypertension, again, just before this, what we discussed. So maybe you have to exclude patients who are at high risk for PIH, that is preeclampsia, because preeclampsia and FGR will definitely have a high uterine artery PI.
yes, ma'am.
So maybe we can go from the first slide quickly. Okay, next. Yeah, next. Not abstract, maybe introduction. Yes. Yeah, here we discussed that introduction, you have to justify your study. Very, very important. If you don't justify your study, then you will not get ethical committee clearance. Sushma ma'am will not give clearance. The scientific review committee and the ethical committee will not give clearance because it requires a lot of funding. Whenever you do a research, you should have a strong reason to go ahead with that study. And when you complete that study and you give the results, you should be able to apply those results in the practice. So it should be impactful. Your results should be impactful. So that way you have to select the research question and justify the strong justification you have to give. And objective, you shouldn't have too many objectives. Maybe one objective and another supporting objective, that we call it as a secondary objective, which anyway will come when we do the whole study. So there should be one strong primary objective by which we usually start our study. So here, what was the primary objective?
So it is to assess the influence of previous C-section scars on the
On
pulsatility index of the uterine artery Doppler.
Yes, excellent. So maybe this objective, they proved this, isn't it? They proved that there is a significant correlation between the previous cesarean scar and pulsatility in the current pregnancy. Did they prove this?
Yes, ma'am. It is
Yeah,
associated
did they
with that.
prove this? Yeah, they proved it. But afterwards, next what? What are we going to do with this data, with this information? What are we going to do? We know that PI is increased.
And
You're
so,
understanding my question? Yeah. So,
whenever
yes, yes.
whenever we detect a higher PI, we can screen them for maternal complications early to
Hmm.
prevent perinatal and neonatal complications.
Okay. So, if it is only a previous cesarean section scar and the PI is increased, we really don't know what we have to do.
Yes, ma'am.
Okay. Only PI increased. We don't know what we should do. So, maybe this is a preliminary study where we found out that PI is increased. So, as of now, we don't have any methods to prevent the adverse perinatal outcomes here, apart from doing only close surveillance. So what we can do here, your answer should be, as you rightly said, you will closely follow them up because they are at increased risk of developing adverse perinatal outcomes. But the same patient, the same study population, if it was a past history of preeclampsia or a chronic renal disease, yes, we have interventions. We have interventions like starting them on low dose aspirin. Okay, so that becomes a strong justification and need for the study when you have an intervention which can be applied if you find out and predict any disease. But in previous cesarean scar, we right now don't know what exactly we are going to do, but we are going to, as of now, increase the surveillance. Okay, next. Yes, study design again, this can be easily done. Prospective study can be easily done here. So there is no need to depend on the medical records and no need to do a retrospective study here. And you can also select which cases you are going to do the uterine artery Doppler. Then, yes, inclusion criteria. Yes, you rightly said, and that was very rightly pointed out that these factors, the women not using heparin, women with no history of uterine surgery other than C-section scar, they all should be a exclusion criteria. So, what is the inclusion criteria and what is exclusion criteria? Pranav?
Now, inclusion criteria are those criteria by which you include them in the study,
Hmm.
and exclusion is when, after screening for inclusion, you exclude them out of the study because they don't fit the objectives of the study.
Yeah, so exclusion criteria should be part of the inclusion. So they cannot be together. So once inclusion criteria are met, then we exclude them, isn't it?
Correct.
Yeah, next. Here, can you tell some exclusion criteria to improvise this study? We just now discussed, isn't it? Women not using aspirin or heparin. Yes, correct. Why they have told it as an exclusion criteria? Because it is
Because
used for prevention of PI, isn't it?
yes,
Preeclampsia, P preeclampsia. So that they have excluded. That should be exclusion criteria. Then chromosomal defects, fetal malformations, they might also have FGR and alter the uterine artery Doppler. Fetal growth restrictions may be associated with that. Then any other exclusion criteria you can tell? Chronic hypertensives?
yes, ma'am.
Yeah, chronic hypertensives, chronic renal disease, autoimmune disease, and any other risk factor for preeclampsia, they should have excluded it. If they want to prove that previous cesarean section is a risk factor for preeclampsia, they have to exclude the known risk factors for preeclampsia.
Yes, ma'am.
Yes, so that could be one of the exclusion criteria. Okay. Maybe type 2 diabetes also.
Yes, ma'am.
Yeah, methodology. So in a see, they have described the methodology from medical records. Can you do that? I don't know. Shushma madam should tell. How
Actually,
exactly
you
the
can
ultrasound?
if you are,
ಅಲ್ಲ
yeah,
ಮ್ಯಾಮ್,
if
ಈಗ
the,
ಅವರು
ಅಲ್ಲ,
ಅಲ್ಟ್ರಾಸೌಂಡ್
ಹಾ,
ಎಕ್ಸಾಮಿನೇಷನ್ದು ಹೆಂಗ್ ಮಾಡಿದಾರಂತ ಬರ್ದಿದಾರಲ್ಲ ಅದು.
ಹಾ.
They have written how
ಅದು
exactly
if
they have
they
done
have
the
done in a
ultrasound center.
single institution ನಲ್ಲಿ ಮಾಡಿ, if they have the institution protocol that everybody goes through Doppler and everybody does ultrasound
Yeah.
like this, then we can
Like
go
this.
back. That's the main problem with retrospective. So,
Yeah.
and the problem is, too many people have done ultrasound also can introduce bias.
Yeah.
Only PI or somebody, if they have done it, then it's okay. In the methodology somewhere he says the PI has done this. So I don't know whether it was planned to be prospective and suddenly became retrospective.
Okay.
Some things like that. But it is difficult when you say ultrasound and all that stuff. They should have
Yeah.
decided initially who is going to do and what they are going to see. Inter observer variability ಬಂದ್ರೆ ಏನ್ ಮಾಡಬೇಕು, all that. No, it can be done in prospective. Retrospectively it adds on to the bias.
Yeah, yeah. Because they have mentioned 1, 2, 3, 4, 5 uh, parameters where this is how exactly the ultrasound was done.
Maybe if the
from the
radiology
medical
department,
records.
whoever,
Yeah,
yeah, yeah, everybody does like this. There, it is only the
yeah.
technician who does ultrasound, I think, in other countries. So I think if they have given them a protocol saying every ultrasound is done like this, then there is no
Hmm.
problem.
Okay,
But it's
so
difficult, as you said, in retrospect.
yeah, so everyone has to follow this same method to do the ultrasound, and if everyone is following, then maybe they can collect it from the medical records that it was standardized, and this is how it is measured. Uh, and I don't know from which year this is data.
From March 2013 to
March 2013 to
February 2024.
February 2024. So much duration, 9 years, huh?
Yes, March
Nine,
14, 2014 to February 2023.
23, yeah, almost, yeah, so many years, 8 to 9 years, to follow a strict protocol of same measurement, because there will be always updates and changes. So from the medical records, definitely you cannot tell that the same routine was followed to do the ultrasound. The same technique was followed. Yes. Next. Yeah. So what is MOM? What
Ma'am,
did you
it is
understand by
actually
MOM?
similar to the INR we get in PT, ma'am.
Hmm.
So,
Hmm.
so we take the mean pulsatility index of one woman and
Hmm.
compare it with the median of the pulsatility indexes of all other women. So normal patients versus
Hmm.
this one patient is the multiple, gives us the multiple of median.
Okay. So suppose a MOM of 2 means what? What do you
So it
understand by
is
MOM of 2?
twice the median pulsatility index.
So if I take a MOM of 2 as a cutoff, what do I mean? More than MOM of 2 means what?
So that means the pulsatility index should be twice as much as the median pulsatility index
Yeah,
of
to
all patients.
consider it as significant. Yeah, to consider
Significant.
it as raised.
Yes.
That the 2 I'll take it as a cutoff, and above 2 I'll consider it as abnormal, and within 2 I'll consider it as a variation from the median. Okay, next. Okay, next. Okay, yes. Statistical tests, maybe Shushma ma'am will be able to tell. So many statistical tests have been mentioned here. Is it because of the uh,
And
complexity
since
of
many
the,
variables
yeah,
are analyzed
yeah,
and the variables fall into both
hmm,
quantitative and qualitative,
hmm,
so different tests are to be used
hmm,
for
hmm, hmm. Yes, okay, next. Yes, so what do you understand by a p-value? Go back. How do you interpret this table?
okay. P-value talks about the probability of being, uh, accepting the null hypothesis when there is actually no change. The probability of rejecting the null hypothesis is less than 5%. So clinically
Hmm.
significant is what we take
Probability
as
of an
4%.
error, yeah.
Type 1
Hmm.
error.
How how do you interpret this table?
They're just telling that their BMI was raised and other variables like smoking and alcohol consumption was significant in one particular.
Hmm. So it is significant for number of previous deliveries and BMI.
So they're telling if the group they're matching the groups, ma'am. Like the BMI in order to assess our variable.
Hmm.
So we are matching all other confounders like BMI, alcohol
Hmm.
consumption, etc.
Okay, next.
So the p-value should, in order to be, we should make it the same. So p-value should be statistically insignificant. That is more than 0.05. But here,
Hmm.
it
Hmm.
is considered as significant, ma'am, where p is less than 0.05.
Hmm. Okay, next. Next slide. Okay, this we have discussed. Next slide. Yeah, again here rationale for including the women at 28 to 34 weeks of gestation that has not been mentioned here. What is the rationale of including these doing the uterine artery PI at 28 to 34? We don't know that.
Yes, ma'am.
Yeah, next. Okay, next. Okay. Yes, fine. Sushma ma'am?
Asha. Yeah, thank you, Asha. Thank you so much. Actually, it was very good learning for me also, because even I didn't think about those risk factors are matching or not. So to
Hmm.
start with, I think you have literally covered everything. Uh,
Hmm.
One was that gap in the knowledge. Definitely, yes, it was not
Yeah.
stated well. And as far
Hmm.
as I understand, what
Hmm.
is cesarean section a risk factor for any perinatal and neonatal outcomes and maternal outcomes is all very well studied.
Hmm.
So I don't think there is anything more you want to add by doing a big study now.
Hmm.
So I think what actually their main focus with the study, what they wanted to do is to focus mainly on that uterine Doppler and
Yeah.
pulsatility index. I
Yes.
what I understand or feel is that they wanted to make that pulsatility index a routine practice for antenatal care.
Hmm.
See that I think the intention was that, and then it
Hmm.
went off in a different direction.
Hmm.
So actually, I think if you start with pulsatility index and have two groups, as you rightly said, retrospective is not a great design here. They should have
Hmm.
designed it in a very nice way, understanding whether taking one outcome. ಈಗ ಪ್ರೀ
Hmm.
ಅಕ್ಲೆಮ್ಸಿಯಾ ಒಂದೇ ತಗೊಳ್ಳೋದು ತಗೊಂಡು
Hmm.
you just take people with cesarean section, no serious cesarean section, and keep measuring that pulsatility index and see what is the association. Is
Hmm.
pulsatility index is associated with any of these outcomes?
Hmm.
Then I think they can go back and make it a
Hmm.
screening mode, that everybody,
Hmm.
those who had cesarean section or two or three cesarean sections, are going to have pulsatility index, because it is pulsatility index is a predictor of preeclampsia, or it is a predictor of growth retardation, IUGR
Yeah.
or something like that. I think that was the intention of starting,
Hmm.
and they
Hmm.
have
Hmm.
put in a lot of effort to this study,
Yeah.
but
Yes.
ultimately the conclusion is whatever we already know.
Yeah.
I think cesarean section, what is its association with outcome, as you said, is already been studied, and there is
Hmm.
no gap in the knowledge at all.
Hmm.
And
Hmm.
pulsatility index, I think they lost the focus in between.
Hmm.
There,
Hmm.
and then if we go back the table 1, table 2 and all that,
Hmm. Hmm.
um, they keep saying it is the influence of cesarean section on pulsatility index.
Hmm.
I want all the students to just look at those tables when they have
Hmm.
done just a T test or a man Whitney test. Whenever we do a man Whitney test or a T test, what it says is whether those two means are different. See, statistically different. So here from that table, what we understand is the people who have undergone cesarean section had higher pulsatility index as compared to patients who did not have cesarean section. Okay,
Yes.
that's all. The heading should be comparison of pulsatility index in patients with or without cesarean section. We
Hmm.
cannot use the word influence or association, because to
Hmm.
say
Hmm.
that we have to do the measures of association. There are different statistical tests. Only with
Hmm.
me,
Hmm.
a man Whitney test, when you say like that, your conclusion itself is wrong. saying that
Mm-hmm.
because of cesarean section they had higher pulsatility index. That
Yeah,
is
yeah, yeah.
not what your Man-Whitney test or your ANOVA Kruskal values they have done. Three group
Okay.
comparison. A table
Mm-hmm.
hogu Pranav. The three group comparison
Yes.
in ANOVA says that the three sample means are different. They're
Mm.
significantly different statistically. That's all. It is not saying because your patient had cesarean section, her pulsatility index is high. You cannot give that kind of a title, saying influenza. It is only a
Okay. Yeah,
comparison
yeah.
of pulsatility index in these three groups. That's all. And
Okay.
if you want to
Hmm.
say whether my pulsatility index is is raised in cesarean section, then you should take the pulsatility index at that 20 to 24 weeks or whatever, and then
Hmm.
calculate the mean, and then above the mean will be high, below the mean will be low. So
Hmm.
outcome is low pulsatility index and high pulsatility index. And here the exposure you will keep as people who had cesarean section and who did not have cesarean section, and then you are going
Hmm.
to do a chi-square test, univariate, and logistic regression. So it is cesarean section a predictor for increase in pulsatility index. That
Okay.
comes
That
that
way. Hmm.
association predictor ಅಂದ್ರೆ ರಿಗ್ರೆಷನ್ ಮಾಡು. ಇವರು
Hmm.
ಅದನ್ನ ಈ ಸ್ಟಡಿನಲ್ಲಿ ಮಾಡೇ ಇಲ್ಲ. So we
Hmm.
cannot say whether the primary objective also has not been discussed properly in their results. Then secondary objective ಹೋಗಿದ್ದಾರೆ. Then we had me and my PGs also had some discussion on table 4, where they
Hmm.
start off giving odds ratio as well as that
Yeah.
adjusted prevalence ratio. See, whenever
Hmm.
we say cohort, it is
Hmm.
always measure of association is always relative risk.
Hmm.
Relative risk is
Hmm.
what is the number of events in exposed divided by number of events in unexposed. It's a very straightforward thing where we are going, because we are going from exposure to outcome in cohort study. So how
Hmm.
many people had outcome in the exposed group and how many people had outcome in the non-exposed group. So it's a straightforward relative risk is measured of association for cohort study, whatever type of cohort study. But in case control study, it is always odds ratio. We, as students, everybody should understand what is the meaning of a risk and what is the meaning of odds. Okay, so odds ratio is because in case control ಏನು ಮಾಡಿದೀವಿ, already outcome has happened. We are going back and seeing how many of them had the exposure. So in a simple way, if we have to understand odds, it is number of how many cases had the exposure by how many controls had the exposure. So usually what we have to remember right now is, if it is a cohort study, we always tell relative risk, and if it is odds ratio, we tell, I mean, in case control study, we always go for odds ratio. So I have never seen a study giving both the ratios. That is where
Hmm.
we got confused, where they've done logistic regression and given us odds ratio, and again next to it is a prevalence ratio. So adu namge salpa understanding maybe we'll require more time, but
More.
this was a
Yeah.
first experience for us to understand.
Hmm.
It became completely, ಆಮೇಲೆ outcome ಈ ಕಡೆ ಬಂತು, exposure group 1 and 2 on the other side. So the whole
Hmm.
group table 4 is very confusing for us to
Hmm.
understand.
Hmm. Hmm.
And then ultimately they said the previous cesarean section and neonatal outcomes and all were not related.
Yeah. Not
So
related.
whatever they started, ultimately what we knew only came out, except for that pulsatility index, which was high in the cesarean section group. But because of
Hmm.
that, what happened, we don't know.
Hmm. And one more
Okay, so
thing,
the
ma'am.
hmm,
Yeah, yeah. You say, you complete it.
no, no,
You were telling
heli.
something. No, one more
No, that
thing.
pulsat,
We don't
yeah,
do a routine transvaginal ultrasound also. It is never done,
okay,
antenatal.
okay,
Only if it is
okay,
indicated.
okay.
Transvaginal is not done.
Oh,
Hmm.
not done at all. Okay,
No,
so
no,
I
no,
just
no.
wanted to know, in whichever country it has happened, what is their
Hmm.
antenatal
Hmm.
guidelines. So I
Yeah.
think it was done in Brazil. We have to just go back and see what is it, and maybe they wanted to see what is the predictive value
Hmm.
of this pulsatility index to an outcome. I think
Hmm.
the design should have been that. Then this study would have had some meaning, saying that pulsatility index had an association with preeclampsia or not. then
Hmm.
we could have just dropped it. Otherwise, as you are saying, it takes quite a lot of resource to do this,
Hmm.
and doing
Hmm.
it in so many patients, and ultimately it is not answering the question what we actually
Hmm.
wanted
Hmm.
from the study. And then
Yeah.
statistics design and choosing the right measures of association. I think
Yeah.
all the students have to know what is relative risk and odds ratio. And many studies, sometimes in cohort, will find both odds ratio and relative risk. All that things we need to understand. What they normally say is, if it is a very rare disease, odds ratio and relative risk will become the same. But if the
Hmm.
prevalence is more, then they are completely different. So we
Hmm.
cannot misunderstand and take different measures of association. Once your design and your statistics are wrong, your result and conclusion becomes wrong. So this here, from this study, what we need to understand is, right from the objective, your design and your statistics and your conclusion, everything should be in one single line.
Hmm.
One mismatch also, there is no point in doing such a big study and wasting the resources. So that
Hmm.
is the takeaway here. And
Hmm.
retrospective cohort also, always cohort andre exposure to outcome. Retrospective means you will go back and again take the patients based on whether they had exposure or not exposure, and then calculate their outcome, analyze their outcome. Just because it is retrospective and outcome is in my hand, we cannot analyze it. So you have to go
Hmm.
back from exposure only outcome. Towards outcome, we have to walk in retrospective cohort study also.
Hmm.
Okay, so I think ಜಾಸ್ತಿ ಆಯ್ತು
Yeah.
ಅನ್ಸುತ್ತೆ ಸ್ಟಾರ್ಟಿಂಗ್.
No, ma'am, it was really nice. Excellent. Pranav also
Pranav,
presented
very
very
good also.
nicely.
Yeah, yeah.
Very
It's
nice.
he's very young to understand the
Yeah,
whole
he's
study, but still,
very, yeah,
yeah,
that's
it's
what.
very
And he has understood it so nicely.
so nicely. Yeah, yeah, yeah.
Yeah.
Very
Congratulations,
nice,
Pranav.
Pranav.
Thank you, ma'am.
Yeah. You did
Okay, I
well
think
and you have understood it
anyone
well.
yeah. Eh,
So if you
Okay, any
have
other
any
questions? I
doubts,
think.
yeah.
Yeah.
I would request Gayatri ma'am to share her comments on the presentation too.
Yeah, thank you. And it was a really very, in its excellent presentation and excellent discussion by both Dr. Asha and Dr. Sushma. I learned quite a lot with this. And what we usually do is we continue the whole this thing we read up, and then most of the time the need for the study we would like to know more in detail,
Hmm.
like you can give some introduction, and then other than what the journal says, because you need to know something before you continue with the journal, no?
Hmm.
And then the review of literature, like you can always look into other studies and compare and see whether the same thing has been done, though this is very complex with so many added variables and all to be compared. It would be very quite a big study at that time. And after coming through all this, then we critique the journal first, from the right from the title, whether it is in the PICO format. Then we see whether the authors have good citations and other things or not. So all that counts, isn't it? And that though the impact factor I heard was good of the journal, the citations also are important. Then the need for the study, whether it is really, I mean, for the society, is it going to help or not? Is it cost effective? All this is also very important. And the results, how they have, which Dr. Asha has very in detail discussed about it. So, and the inclusion and the exclusion criteria, the sample size, all that in that critic, this thing, no, we put side headings and we will critique it. So, the more importance was given to the methodology, the results, and the discussion part. So discussion, we have to critique whether the journal has done any discussion comparing with other studies. And then you can also, I mean, that is what we usually tell our postgraduates to look and see if there are any other studies other than what cross references are given. Na? So with that, read that and also look whether we can compare other things also. So that is how we do it. But it was really very knowledgeable, and I really learned quite a lot, and it was really very extended and a comprehensive discussion. Thank you, Dr. Asha and Dr. Sushma.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you, ma'am. As ma'am mentioned, the cross references are very, very important. So if you go through that, I think one more person also could have done similar kind of study. At that time, comparison becomes easier. So that cross reference reading is also very, very important.
Hmm.
Okay, thank you so much, ma'am. Thank you so much, Asha, joining the
Thank you, ma'am.
SRC and
Yeah.
making it so good.
Thank you,
Yeah,
ma'am.
so yeah, I think it's getting late also. So if we have any questions, we'll discuss on SRC platform. And I think
Can we take some audience questions, no? Like if there are
yeah,
any.
if yeah, if there are any. Yeah,
Good evening, ma'am. Ma'am, I was reading an
yeah, go on.
article a few days ago, ma'am. It was published in European Journal of Pediatrics. So their objective was to, in their study population was pediatric population who were suffering from a tuberous sclerosing complex, and in them they wanted to see if renal abnormalities are more in obese children or in malnourished children. So after they told it was a retrospective cohort study, and in their methodology they never compared two groups like group one which was exposed and group two which was not exposed. They just took the group which was exposed and they have done certain statistical tests. And in one of the table they have mentioned odd ratio. Like I wanted to know how did they conclude to odds ratio without having a control group or a group without an exposure.
So, Sushma,
That we have to read
Sushma.
the journal. That
Yeah,
we have to read the journal. I think then you send me the article or meet me. I think we should be able to see,
yeah,
because without reading it, even I'm unable to recollect it. Based
yeah,
based on
Okay,
this
ma'am.
article, if we have something, we'll discuss. Otherwise, I think you can do a journal club. I think you have done read it quite thoroughly. So next time we can take that
yeah,
and discuss the statistics
Okay,
in
yeah,
ma'am.
detail.
yeah.
Thank you, ma'am.
Thank you everyone for your active participation in today's Journal Club Week. Thank you to our presenter Pranav Bhat for delivering an detailed presentation. I would like to sincerely thank our moderator Dr. Ashakiran ma'am for her invaluable efforts in guiding today's session. Ma'am, your expertise, insights, and dedication have truly enriched our discussion. We are grateful for the time and energy you put into making this meet both successful and engaging. And I would also like to thank Sushma ma'am on her detailed points about odds ratio and the methodology, and Gayatri ma'am for her comments too. Thank you again, everyone, for your participation. Have a great evening.
Thank you, thank
Thank
you.
you. Thank you.
Thank you. Well done, Pranav. Thank you. Good night, everyone.